Hello, Jonathan. Shruti, how are you?
Good evening.
Yeah, good, thank you. How are you doing?
Yeah, very well. Now, thank you for joining us. So, we've just basically had a panel of ADHD coaches talking about the kind of challenges that ADHDs bring to coaching and how, we help them overcome those challenges. But what I thought would be really useful for participants, obviously, to understand the role of psychiatrists in supporting ADHD and also how you work with ADHD coaches to help, even further improve your patients' outcomes. So it'd be great to maybe just ask a few questions, and also there might be some questions from the audience. But yeah, Shruti and Jonathan, we work with them, and we share some patients in common. Been working together for a couple of years, and with great success, I'd say, for some of our patients in particular. So shall I maybe start with you, Jonathan? Did you want to maybe just introduce yourself and just kind of explain how you support ADHDers?
Sure. So my name's Jonathan Ornstein. I'm a general adult psychiatrist. So I've been working with ADHD for about 10 or 12 years now, actually. So I started off working primarily in the NHS, so in Southwest London. And for the last 10 years or so, I've been working privately. So I do a large number of ADHD assessments, and that's looking at whether a person has ADHD. So that's a full history, use of some standardized questionnaires, but really just almost more importantly, understanding what the challenges are for people individually. So if they've got the diagnosis, how does that actually affect them day to day in terms of their life, and what is it they really need help with, or what they want to change? From a medical point of view, primarily, we look at medication and make sure we safely monitor those and make sure that they're actually effective and they're the right medication. But of course, ADHD is much more than getting the right medication. Medication is the fuel often to get people functional, but beyond that, it's about, again, going back to an individual's life and what they need, and what's lacking, or what they need support with, and how best they can get that. And often for those factors, that's where I sort of very readily and happily turn to coaching. So that's sort of my role.
Thank you, Jonathan. Shruti, did you want to maybe introduce yourself and kind of how you see psychiatry
So
assisting with
thank you,
ADHD?
Stephanie. My name is Dr Guruswamy. I'm an adult psychiatrist, and just like Jonathan, I work with a lot of ADHD and have done so for a number of years. I'm predominantly in private practice, and I have my own practice. I see people at various locations, primarily sort of virtually as well. A lot of people seem to like to work virtually these days, and Harley Street as well. As I said, I love working with ADHD. And my job is to, a patient walks in and I want to take a complete history. And as Jonathan said, I want to understand the person. I want to know what are the difficulties in their life, what challenges have they faced, what influences of their life do they have in their life that perhaps affect their ADHD, and what exactly do they want to achieve understanding the neurodiversity. I put a lot of emphasis on understanding the brain, understanding neurodiversity, understanding the elegance of the brain. And it's very much about empowering people to understand that actually ADHD can work for you. It isn't actually difficulties as such. And as again, Jonathan said, our job is to look at medication, but medication isn't the be all and end all. I work very integratively, and that's how I sort of see psychiatry as a multimodal model. And I look at building a scaffold around the patient. Each patient obviously has their scaffold tailored to their needs, but ADHD coach is integral to that. The psychologist, maybe the PT, maybe the dietitian, whatever the patient needs, depending on comorbidity and need at that time. Sometimes family therapy is even needed, just depending what psychopathology and comorbidity is. But ADHD coaching, in my experience, has been fantastic, fantastic addition to actually help a person understand their ADHD, and not so much from a sort of a neurodevelopmental level or a clinical level, but more on a day-to-day level. How do I manage things? How do I manage work? How do I juggle work, life, family, home, friends, myself? And also, being able to carve out time for the self and carve out time to actually give the self, sort of meet the self's needs about what a person needs, and how to actually manage and prioritize that time in terms of executive function, about what exactly do I need in this moment in time and how do I go about achieving it. So ADHD from a coaching point of view is incredible, but also from an understanding the neurodevelopmental difficulties and actually accepting the difficulties is very, very important. So
no, yeah. So the message there, taking that kind of holistic approach and very much honoring the fact that, ADHD it kind of takes a village, in terms of supporting them, and in order to thrive, and making sure you've got the kind of right people in place, the support networks in place for each individual. So thank you for that, Jonathan. So I remember when you first reached out to us, I just wanted to, maybe you can kind of explain what made you as a psychiatrist reach out, for coaching for your patients. What kind of led you to that?
Sure. I mean, so when people come to see you, they tell you what they're struggling with, and not just what they're struggling with, but what their ambitions are and what they're trying to achieve. And an issue, of course, of ADHD is the frustration and often associated anxiety and depression that can occur with the gap between what you feel capable of doing and what you find yourself able to do day to day. So you can see the goal you want to get to. You feel intellectually and in terms of ambition and ability to work hard that you can get there, but somehow putting the pieces together seems impossible. Bridging that kind of gap is really hard. And actually, again, when you get the medications right, sometimes it fixes those problems to an extent, or it can sometimes fix them altogether. Some people just need that bit of a boost that the meds can give them, and away they go. But a lot of people, they may have had quite a long period of frustration, loss of confidence, feeling incapable. So even though they might have the tools and the capability, they don't necessarily understand that they do. So helping somebody create a structure for themselves and a sort of roadmap, if you like, of how to get where they want to get to is vital, and it helps day to day, and it absolutely helps with mood, anxiety, and any other sort of comorbidities that might be there. What I found was psychology can be very useful, but often wasn't really precisely what my patients were needing at that point. It really was the sort of life coaching skills, the day-to-day skills, the practical skills, that sort of co-pilot to help them get to where they want to get to, and coaching sort of reaches perfectly in with that. And so I've not been disappointed for the most part. It's exactly what I think people need. Not just people with ADHD, by the way, but that happens to be a particular gap or need that's there to be filled. And when it's done properly, it makes a massive difference.
Thank you, Jonathan. I was going to ask as well, just for participants, in terms of the kind of patients you see, like, and the diagnoses, obviously the pandemic, there was a lot more, I guess you guys have gotten much busier. But what just a comment on, how much more ADHD, kind of you're seeing people coming to you for assessment, and obviously the wait on the NHS. Any advice for people that are waiting would be great.
Is that for me or for Shruti?
Let's start with Shruti.
Unfortunately, since the pandemic, Stephanie, you're right, there's been an explosion or tsunami of psychopathology, and not just ADHD, multiple psychopathology, and for various reasons. As we said, I think as you see, and I think Jonathan's the same, we've taken on as much as we can. There are waiting lists nonetheless, and on the NHS, I do believe the waiting lists are quite long. I always tell people ADHD, 30% is about medication, 30-40%. 60 to 70% is about behavioral strategies, behavioral modification, behavioral systems, and psychoeducation. So my advice for patients who are on the waiting list, and it's hard, and unfortunately that is the way it is, try and educate yourself as much as you can about ADHD. There's some brilliant resources out there, some really, really good, and there are a myriad of resources on multiple sort of media channels, not just the internet, but TikTok, YouTube. There's some online magazines. Get in touch with the ADHD coaches, ask, learn, and learn as much as you can. Empower yourself, because so many things as adults we are doing already, and it's about just refining your techniques and making life easier, more manageable, and more understandable for yourself. The more you understand your ADHD, the more empowered you are. Knowledge is power. So by the time then you finally do come to myself or Jonathan, you have a good bit of the skill set in place, the behavioral systems in place, and actually then what we're doing is just the tweaking and the cherry on the cake. So that actually you're taking control and you're leading this journey. It's your journey. take control. We'll be there by your side. But this is a journey that you are in the driving seat for. And I always really emphasize that to people.
Sorry, I was on mute. Jonathan, did you want to share your experience?
Yeah, I mean, part of the issue with the NHS, for example, even pre-pandemic, was that, I worked Southwest London, St George's Mental Health Trust. Now, geographically, that covers about a quarter of London, not necessarily in population size, but at least physically. And when I said I worked for them, I was the service, and they gave me one afternoon a week. So you can imagine the waiting list that would build up over that. And it doesn't seem to have changed. There is Psychiatry UK now, which is supposed to be a sort of more nationwide virtual service for assessing ADHD. And they've certainly got some good people working for them. But again, the waiting list seemed pretty hefty. And on top of that, the follow-up seems incredibly slow. So you might get an assessment, and then it seems to be about a year till you get a follow-up appointment. So there's massive issue. There are only so many psychiatrists. ADHD has taken off in terms of public awareness and understanding of it. And I think many people who previously would have been undiagnosed are now starting to understand they may have this. I think until there's a shift in it being seen as a super specialist type of diagnosis, then I think there's not going to be much of an answer on the NHS. I don't really understand why it's still seen as a super specialist diagnosis. I think the training is relatively straightforward as an adult psychiatrist to be able to assess it. Literally you can do it in a couple of days, given the basis of your knowledge of how to take a psychiatric history and psychiatric pathology in general. And also it should really be part of the basic psychiatric training that they do in the exams, so you don't even need that specialist training afterwards anyway. And that's something I think probably is worth campaigning for. There is an issue, therefore, for people that can't afford private assessments. Some of the private assessment costs are huge. There was a recent documentary also about some of the quality of it. I think that was a very unfair, overcritical documentary, but nonetheless, the point remains. So it's very tricky. Also, insurance don't always cover it. Not that I'd ever recommend this, but if a person thinks they've got ADHD and they also happen to have some depression or anxiety, perhaps that might be worth emphasizing more to their insurance companies than the ADHD, for example. So, it's a matter of finding somebody with availability. And I'm sort of booked up till about March at the moment, ridiculously. It's being able to afford it. It's hopefully being able to get insurance for it, but it's also worth probably getting in the queue in the NHS anyway. You may get lucky. There are cancellations. Things can sometimes shift very quickly. And even if they don't, at least you're in the queue. And I guess it's a matter then of, if you can't get a medical diagnosis, it's a matter of reading about it, finding out about it, looking at strategies for it that you can do before perhaps you can be prescribed. And, if you can access coaching before medication, maybe coaches will have connections that can get you a bit of a shortcut if you can afford that. And again, using access for work to perhaps help for funding for the coaching can be useful as well. So it's tricky. It's really tricky. And it's not just ADHD, by the way, it's all areas of mental health, unfortunately. And in fact, I was going as far to say all areas of health at the moment, due to sort of chronic underfunding and crises within the NHS, leading to some massive spillover into the private sector. But this is, at the current time, the world we live in. It may change at some point.
Thank you, Jonathan. And so, yeah, my internet, sorry, apologies if my internet is being a bit funny right now. I'm at the top in the loft. But Shruti, Jonathan said something there about super specialist, I guess, in terms of diagnosing ADHD. What are your thoughts around, that?
I would agree with Jonathan. Public awareness has really sort of opened up about ADHD, not just ADHD, neurodiversity. People are a lot more aware of autism, specific processing difficulties, and all the other difficulties that may encounter: dyslexia, dyspraxia, dyscalculia, dysgraphia. And actually, by virtue of people being more aware of these difficulties and understanding these difficulties are surmountable, there's a lot we can do about that. There's a lot we can sort of accommodate and make reasonable accommodations for. I think neurodiversity should really go into mainstream psychiatry now. And as Jonathan said, it is still seen as somewhat a super speciality, and unfortunately so, because there's so much associated comorbidity. And when a patient comes through with ADHD, by the time they come to us, very rarely do they just have ADHD. Very often people present with comorbidity because we know that people with untreated ADHD are more prone, and the evidence shows that they're more prone to recurrent generalized anxiety disorders, recurrent depressive disorders. So we do know that these need to be treated as well. Again, as I said, to the sort of the increased awareness, both on the private sector and in the NHS, waiting lists have gone very, very long. So like Jonathan, my waiting list, given the fact I work in the private sector, is still very long, because I don't think there are just enough psychiatrists all around who are trained up in ADHD and or perhaps have the inclination, because obviously different people have different, clinical interests, and that's a very personal thing as well. But given the public sort of knowledge, the public awareness, and given the fact of its prevalence, which hasn't actually changed over time, the prevalence still stays about 7%, but that prevalence hasn't changed. It's just the public awareness and the public understanding that actually we can do something about this, and life can be so much better. It doesn't have to be so hard, that people are seeking help. And again, how the various avenues of finding that help are myriad. It is difficult given the health service and the state of the health service right now. It is difficult given the state of the economy right now. It is difficult with all the other factors that are confounding people's access to getting sort of speedily treated. I don't have one particular answer, but all I can say is keep trying and trying again, and somewhere something will work out and people have access to the treatment they need.
Yeah, it's not easy, and obviously doing everything you can. There's only so much time as well. I was going to ask as well, with your diagnosis, procedure. Obviously, the DSM-5 at the moment doesn't include that emotional dysregulation piece, which is so pervasive, such a huge kind of indicator of ADHD from what we can see anyway as coaches, and particularly around the rejection sensitivity. What do you factor in more of that kind of functional, Dr. Dodson's definition of ADHD, in terms of recognizing the emotional dysregulation piece of ADHD? Do you look out for that, and how much of that weighs into your diagnosis? Yeah, Jonathan.
Shruti, okay, sure. Yeah, no, it's really important, and it's certainly part of the history taking. So, you're looking at a person's mood, how they react, how they respond, how their relationships are affected, how they see themselves responding to things. Often there's something you almost see in ADHD, almost a person looking in at themselves going, well, why am I doing this? It could be they've got a job to do and they find they're sort of staying at their phone for an hour instead of doing it, and they're almost out of body going, why am I doing this? But actually it's the same emotionally. I've just reacted to that and I'm feeling this, but they're almost hyper aware of their logical parts of the brain going, why did I just react like that? I don't want to react like that. And there it is. And that, of course, can deeply affect interpersonal relationships, work, and all sorts of things. So it's certainly part of the history that you take. It's not necessarily included in the standardized testing you do, but that's okay. It's sort of, you're mostly there looking at the hyperactivity and the attention deficit. And if it's there, you do a full history. You take the details of it, how it affects them, what happens, what are examples of it, how does it affect people around them? And then you also think it through in terms of treatment. If that's actually the predominant thing causing them distress, is that something you're going to maybe target before attention or inattention or hyperactivity? Is that something that actually maybe at that point, psychological input could be very useful for? Is it something that they're going to do mindfulness exercises? But of course, those things are very difficult when you've got ADHD. Is it something you could consider medicating? And I've had quite a lot of success, for example, with guanfacine, which frustratingly isn't licensed in adults, but even at very low doses tends to have quite a dramatic positive effect on those kind of symptoms. So again, you're going back to the idea of what's important to the person in front of you. You might have this diagnosis, but what does it really mean? What does it mean to them? How's it affecting them? What are you prioritizing? And of course, you use patient choice. here's what I don't like giving people 2 meds at once, but if we're going to focus on one thing we're going to treat medically, what's your priority? And if they're not sure, then weigh it up with them. And if they're still not sure, you go, well, let's try this first and see how you find it. And if that's good, then great. And if not, then we can try this instead, or as well as. So, it's that collaborative work. I'm going to suggest you try this. You tell me how you get on with it, and we'll work out together, are we on the right path?
Yeah, it's tough, isn't it? Because it's it's not an exact science, and I guess you are relying on ADHDers to give you reliable accounts. And remember, yeah, yesterday this is how I felt. Quite often ADHDers, one, won't clock how they're feeling, and usually they're so busy, or they're always in this state. And I found that what's been helpful working with some of your patients, particularly those that are titrating, it's helpful to kind of, in coaching, we can see as coaches, when they start something different, and we can kind of observe and we can coach them, in real time around, okay, so, how did you feel at what time did you start, did you start feeling like the attention was going, we can document it, and then we can share. That's another really, I think, a big benefit of working together, being able to, I think, hopefully that helps you guys, work out as well. Well, hang on. Yeah, this is what your coach observed. So that's another, I think, benefit. Would you say, Shruti, would you say that that's kind of an accurate?
Absolutely. I think coaching brings in that sort of multidimensional aspect that perhaps we might not see with the patient because we're in a clinical setting. But to echo Jonathan, what he said just now, I agree very much. It's the qualitative impact on the symptomatology. Now, we know the cardinal symptoms: inattention, hyperactivity, and impulsivity. But the manifestation of those symptoms are a myriad of ways, not just on your personal, professional, psychological, social life, your financial conduct, sort of your developmental history, your parenting, how you parented yourself. And as a result, the impact can be in very subtle ways even. And one of the things that people really struggle with, and actually it's quite an exhausting way to live, is the emotional dysregulation. The up and down and up and down and up and down, to exist in such a way, which is actually a manifestation of ADHD, and perhaps one, as we've discussed, the psychometrics don't necessarily quantify or qualify. It's something as we as clinicians recognize because it has the impact, the qualitative impact on our patients' lives, and causes subjective distress, which is something we are constantly looking for. And one of the things I find is psychological input very, very useful. And something I'd use a simple strategy is I refer people for DBT skills. And these are skills groups where they join other people in a skills group. Now, DBT can be used again for a variety of psychopathology, not just ADHD, but I find it very useful for ADHD because the 5 core skills are very here and now practical skills to help manage ADHD, including emotional regulation, distress tolerance, self-management, mindfulness, and interpersonal effective communication. And as I've just said, those are very practical here and now skills. And if a patient can use those skills as a building block to help manage distress, and then take those skills and take them to coaching, actually, and apply those skills in coaching, they can even make better use of what the coach has to offer them because they're able to manage the self and then take on more by being able to manage the self. So these, again, is building blocks to get the person to where they want to be.
Yeah, no, and DBT, it is so effective. And we've got Dr. Vic Patel, we had him on yesterday talking about the benefits of DBT and how it fits with coaching as well. And it's exactly what you said. And quite often when we have an ADHD that might be waiting for a diagnosis or maybe waiting to take medication, we will say to them, we'll be upfront and say, look, in terms of, the focus, medication's very good to increase your attention, your focus. You'll probably find coaching will be more effective once you're medicated. We want to be upfront and give them the best possible, chance. That sometimes ADHDs, they don't want to try medication, in which case, yeah, they come directly to us for coaching. And obviously, we'll coach them. But we certainly, as coaches, we can see the difference. It is definitely harder for the ADHD to execute and not go off on tangents, obviously, as well, when you're coaching them. So it will be more effective with the medication we've found. And the same thing, I guess, like you said, with DBT and therapy, because we might set them in action, they may set an intention, but emotionally something will get in the way, and boom, because they don't have the skills to manage themselves, or maybe not, have a meltdown and maybe disrupt some kind of relationship, that it all kind of obviously has effects. They're not able to execute on the thing because they're just so emotionally dysregulated. So those skills, really important together, obviously with medication to help them hold the space and to pause and to focus. Yeah, it all really very much will help with the coaching. It's all very much kind of impacts, like you said, the building blocks. The more building blocks, the more they fit together, the stronger the foundation we can create for that ADHD, for sure. Yeah. So the other thing I was going to ask, what we found as well, quite a few girls and women with ADHD struggle to get a diagnosis, particularly girls in education. And the reason for that, obviously, I'm sure is that the school will not see the hyperactivity, the impulsivity, and yet at home, the child will be coming home and having meltdowns. The family sees it, but then because you need to have ADHD present in at least 2 settings, there's that obviously difficulty in getting the diagnosis if the school's not on board. Yeah, what do you see this, and how do you work with this? It'd be great to hear about that. Jonathan?
So, well, I don't really work with school-age children. I only really work with adults. But what I often see are adults who are frustrated when they look back on their school career about how they feel they've essentially underachieved, or it was much harder work than they felt it ought to be. And that pattern follows them into university, whereas at school they can perhaps hold it together, either because they're sort of that intellectually robust that they don't have to concentrate or pay that much attention to do well at school, or else the structure at school and at home is so good that the things they would struggle with without that structure is sort of taken care of for them. Of course, they go to university and boosh, it's all kind of gone. Or even they get to university and they get to work and it's a nightmare. But then they look back and they see what's what. I think really it comes down to better understanding this idea that schools have to speak to the home. Schools have to understand that things manifest themselves differently in men and women, and there are a lot of gender issues and gender identity issues at the moment, which are very politically to the fore. And so it's probably a better way to put it is not so much that things show up differently in men and women, but things show up differently person by person. So if you're seeing somebody struggling, if you're noticing that your student may not be disruptive, but essentially they're staying out the window all day long, they excel in some subjects, but absolutely fail in other subjects. If at a parents' evening, it's a sort of two-way communication. If as a teacher you've noticed those kind of traits, it's probably worth discussing with the parent, how are they at home? And then actually, rather than saying it's in 2 domains, you're understanding that people act differently in different domains. And so that's got to be taken into account. But yeah, it's incredibly frustrating. I'm not advocating that if you're a woman and you think you've got ADHD, you should start sort of jumping on your tables and throwing your cups across the room. But, it might be a matter of education across the board, so people themselves recognize perhaps I've got ADHD. Parents are better able to recognize, okay, this is what we're seeing, and it's not there at school, but we understand that can be quite a typical presentation. And so let's not rule that out. And of course, people doing the diagnoses to understand that as well. We have diagnostic guidelines, but in all sorts of cases, people don't always fit very neatly into them. So you have to be a bit flexible with your understanding of what they mean and understand they are guidelines rather than absolute strict and rigid rules.
Thank you. Shruti?
Well, to add to that, I think as well, historically, we thought the incidence of boys to girls was 10 to 1. Now we know the incidence of boys to girls is 1 to 1 because girls mask, they model and they mask. They model their peers, they look at the peers, they model their peers, and then they mask much better. So actually, that concept of ADHD being pervasive is actually quite obsolete because girls are able to mask in school. And yet when they come home, obviously all that tension that they've held and they've held it together, it falls apart. So they can present differently at home. I think as well, on the whole, if you look at baby boys and baby girls tend to mature faster than baby boys. They're walking, talking, all the developmental milestones on the whole, generally. And I think we can extrapolate this even to sort of teenies, tweenies, and that kind of thing. Girls tend to mature that little bit faster than boys, even physiologically, if you think about it. So you have a girl, a young lady, and you have a young gentleman. Chances more than often are not, the young girl is a little bit more mature than the boy, and she understands what's appropriately social, and she's been appropriately socialized because she's more mature. So you have a young lady and a young boy at the same age. The boy may present with more overt symptoms. However, the girl presents with more covert symptoms because she has the emotional wherewithal to understand what is appropriately socially expected of her. So she can actually hold that together, mask the symptomatology, and yet have the same amount of struggles and go undetected compared to the boy. And I think the oldest patient I think I've ever diagnosed de novo was a 78-year-old High Court judge. And this lady actually had ADHD, and she couldn't believe it. But because she was able to mask, she was appropriately socialized, and also she was very, very clever. Nobody ever picked it up, including herself. And I suppose, again, if you think about the generational thing, but it's there. And I think we are getting much better as mental health professionals, as clinicians, as GPs, as even the lay public at understanding what ADHD is, understanding it's a neurodevelopmental phenomenon, understanding the difficulties that are surmountable, and there's a lot we can do. So people's awareness is actually, exponentially exploding on this. And that actually is for the greater good of the public.
Thank you. We've got a question from someone. Do you have any advice regarding the various nootropics on the market as an alternative to prescription medication? Nootropics?
Do you want to say that, or shall I?
Can't you start?
So there are a number of supplements where there is some fairly weak evidence that they can be helpful. So there's an evidence-based paper about saffron supplements, for example, but that study happens to come from Iran, where they grow a lot of the saffron. So there's a slight take it with a pinch of salt or saffron. There were some supplements available in Israel called Zoom, which was a very high-strength vitamin B supplement. There's not a lot of evidence in it, but there's a lot of anecdotal evidence that it works. The same goes for something like Lion's Mane supplements. Now, most of these are pretty harmless, except sometimes to your wallet. And all I'd say is that if you don't want to go down conventional medical route, or you can't get an appointment, and you try these and you find them helpful, then fantastic. But as doctors, we sort of try and go for evidence base. We try and go for these things being rigorously tested to see, do they work in a way that can be proven, and that's done in sort of double-blind studies. So the person nor the tester knows what's being taken, and rates the results objectively. So there are those things. As I say, most of them I think don't do any harm. They may not do any good. You have to watch how much money you're spending on them and go from there. There is a lot of excitement, as happens in the medical world at the moment, about a new hot topic, and one of the sort of hot psychiatric topics is inflammation, more about anxiety than anything else, but sometimes also depression, that essentially if we have an overactive inflammatory response to any kind of injury or infection, then that can very much affect our mental well-being. And there's something in that seems to sort of lend to a form of syndrome of ADHD and sort of hypermobility and things like that. And so there's a supplement called resveratrol, which is essentially an anti-inflammatory supplement. There's some evidence in children, if taken in conjunction with ADHD medications, can make those ADHD medications more effective. Again, they can cost a lot of money. The evidence is not strong enough that I think most doctors would advise it sort of off the bat. But I'm more than happy to sort of, if you want to give it a go, it's not going to do you any harm and may do you some good. So go for it. But it's that understanding of, this is where there's evidence, strong sort of very scientifically, rigorously proven evidence. And this is where the various things on the market fall. And some of them don't even reach a level that can be visible. No research may have been done on them at all. So be cautious with your wallet, be cautious with how you respond to it. But if you find it useful, I'm never going to tell you to stop taking something if it does no harm and you think it does some good.
I was muted again. Thank you. So the other thing, obviously wanting to talk about coaching and the outcomes that you've been able to see in some of your patients. It'd be good, for the participants to kind of understand how coaching has been able to help enhance maybe some of the outcomes of ADHDs, but particularly interested in kind of what you think has moved the dial in terms of the coaching, in terms of them understanding their ADHD, accepting their ADHD versus, kind of rituals and planning and prioritization, that kind of thing. Be interesting to hear from you in terms of the patients that we've worked with together. What have you found most impactful, would you say, from the coaching? So Jonathan.
Do you want me to answer this? I answered the last one. I don't know.
Okay, sure. Okay, yeah, I'll give Jonathan a break. Shruti, because we've obviously had a recent conversation with a patient and her parents.
I was going to use that as an example. So actually, this was about last week, actually, and I have a patient, a long-standing patient, who has done phenomenally well. She came to me quite unwell with comorbidity of depression, anxiety, ADHD. There was an additional diagnosis of ASD as well. So I'm not going to go into that because that's a whole different session. In either case, this girl came in very, very timorous. That's the way I would describe her, with no confidence, no self-belief, very isolated, and again, quite unwell. And it was a process of sort of laying everything out on the table, understanding what she presented with, understanding not just psychopathology, but the impact on her, how she felt, what was the impact qualitatively in her life? What sort of social life did she have? Did she have a sense of belonging? Did she feel comfortable? And again, the familial system around her and the social and environmental system around her as well. So what were the impacts of her neurodevelopmental difficulties and all the systems around her? Even her own sort of career and educational systems. And she, again, we very much went with the multimodal, multidisciplinary model. So we had psychiatry, psychology, ADHD coach. We had a gynecologist as well, and the GP, of course. And we came around and everybody doing their part, taking their part of the pie and working on their part of the pie. And it was a slow process because, nothing happens very quickly in psychiatry, but to effect change and make change long lasting, you have to make a change that's doable. So it's step by step by step. And this girl, I can unequivocally say she took us a long time to stabilize because she was quite unwell when she did come in. But slowly through time, working with her, reviewing her, having the coach, a therapeutic bond between the psychiatrist, between the psychologist, between the coach. Again, that coach, the therapeutic bond with the coach is very, very important. And I think from a coaching point of view, we know what psychiatry and psychology do, medication, therapeutic work, all that kind of work, resilience skills. But the coaching, I think the biggest thing coaching was able to give her was self-confidence and self-belief that I can do this too. I'm a clever girl, and she is very, very clever girl, has very niche skills that she has actually found the niche for, and I'll talk about that. But I think the biggest thing, it was to give her the confidence to do the things that she knew she could do. So much so, after having a few difficult jobs, she's actually started her own business, and the coaching has actually given her the background structuring and the background information, the background sort of foundation blocks about how to build her own business, websites, she's using words like networking to me. She's doing things that she's got an accountant, she's got the legal team, she has all her policy and guidelines. This is a girl who was so unwell that she could barely leave the house. She didn't believe she could do anything. And now she's got her own business. Coaching has also helped on a more sort of basic but actually problematic and fundamental level about looking after herself, managing what we call ADLs, activities of daily living. She very much had a family who were very involved with her because she was so unwell. So simple activities of daily living, cooking a meal, running a home, were difficult to her, and actually coaching gave her the skills. And these are skills that an adult will almost be embarrassed to ask for, and she was, but actually coaching gave her those skills and helped her learn those skills without any judgment and therefore no shame, which then further did not contribute to her sense of low self-esteem. This girl, when we saw her, Stephanie and I saw her last week for a family meeting, just to see where we're going, where we're progressing, how things are going. She now lives in her own property. She runs her own home. She manages a beautiful home by herself. She has her own business. She's made a small and select group of a social circle. She gets out and about. She does things. She's so much more independent. And more than anything, it's the belief, I can do it. My neurodevelopmental stuff doesn't hold me back. I can do it. And that, to see this girl blossom, that's incredible. That's absolutely incredible.
Yeah, no, she is remarkable. And we were talking about the journey, you're right, when she first started. I think she just was getting a job, and I think we were working on the morning ritual, how to get out the door, like how to get to work, because of her autism, how to, because of all the sensory challenges of going on public transport, working out kind of how to navigate that. And then very much in the workplace in terms of the relationships, because she was very rejection sensitive and socially anxious, how to navigate lunchtimes. I still remember her talking about, quite specifically, there's time they go to the courtyard, and we actually would even do a bit of role playing in terms of how the conversations would go, so that she was kind of a bit more prepared and confident to have those conversations. So she, that's kind of where we started. But from there, the more we kind of did work around realizing what her strengths were, so uncovering those strengths and things that she'd achieved, her values, you could see, and I kind of, because she is so clever, like you said, really, really clever, very detail oriented, very, very high standards. And, I could see that a lot of these strengths led to leadership qualities. These were very much kind of leadership strengths. And so, we worked on kind of what she viewed a leader to be. And, she could kind of see and started to get evidence like in the workplace as well, because she moved on to that next workplace. I helped her, with the interviews. We did a bit of role playing around that as well. Building her confidence, like you said, very much all about building her confidence and being able to, refer to these strengths, these values as, kind of, backing, really. This is evidence I can do these things. And, she got that great job, and literally she kind of very quickly, found her place in this organization. But more than that, and we talked about this in the coaches panel, because of her eye for detail and the systems, she's so good with systems, she could see all the inefficiencies and was then trying to kind of raise the standard in the workplace, because she could see what needed to be done, and she wanted to do a good job, and she really cared for the things that she was looking after. And yeah, some of the stuff she went up against, like, her manager was very difficult, needed to be managed, basically, sounded like very ADHD himself in terms of, but the opposite to Sophie, more the forgetful fairy type in terms of not really having an eye on things, not being very responsive, not really having very high standards. And she was having to navigate some really difficult conversations. And again, just the contrast between the problems we were coaching around before in terms of navigating lunchtime versus some very tricky, very rejection, sensitivity triggering conversations. But because, she started to really get more confident and really, she became quite proud, of her values. And, in coaching, we were kind of always showing her, this is the evidence, this is what you're doing. And this is, she was getting the right perspective, and she was just becoming even more resolved to stand her ground and keep to her values. And that actually led, right, to her eventually leaving that workplace and setting up on her own so that she can do it her way. And so she can reach that standard and hold whatever company contracts her to do the work. She's able to make sure that, she's going to be able to deliver to the standard she wants to, and that the organization she chooses to contract with align with her value, because that's where she's going to thrive and be happy and do her best work. I mean, this is where she is. This is what she's been able to achieve, which, with the help of you in terms of the medication, because there's, not just one medication, It took you, I could see, a while to get to that right level. It was the combination of that and the way you explain, your psychoeducation as well, plus the coaching, the therapy. We got her to an amazing level. Like she's thriving, absolutely, and now living on her own in her place, which is incredible. She's definitely one of our greatest success stories, I would say. Yeah, so it really does work. But I was going to ask, with the parents that you deal with, do you see a lot of ADHD? Because it is very genetic. Jonathan, your turn now. You've been quiet for long enough. I'm going to call you out. Go on.
Well, it is highly genetic, and often a way people come to me is that their children have been diagnosed with ADHD, and they go, "Hang on a second, what's going on here?" And the amount of times they get asked to sort of see siblings or cross generation. I mean, as a rule, I don't see partners. I just think different partners should have different psychiatrists. I think sometimes, if they want to talk about their other half, it can be difficult. Whereas children and adults and siblings, I think it's easier to sort of keep those boundaries managed. But again, the evidence is just it comes down to when you break down the cynicism about ADHD as a diagnosis, it seems ridiculous given the sort of very strong genetic preponderance, the very good responses to treatments, and a very clear sort of understanding of the syndrome as a whole, of what goes together and how it goes together, and our greater understanding the understanding that's growing of the sort of neurochemical and neuroanatomical basis of it. It's really quite something. And as a psychiatrist, it's sort of quite, for the most part, a rewarding condition to treat, in the sense that actually people can get better relatively quickly when people are pointed in the right direction, and get the right help, the right support through coaching, the right understanding through education, the right treatment potentially through medication, and the right sort of understanding of their place and why they've had a struggle, that there's an answer to why things feel more difficult to them than they feel they ought to be or seem to be for their peers. Again, the amount of relief people get actually for getting a diagnosis is really something. So, as I say, so coming back to families, it definitely runs in the family. The understanding of one person helps the other member of the family understand themselves. You can always see a sort of veil lifting. And then, treating it can be just really, really rewarding. You see people's, we think sometimes in terms of symptom relief, but actually in ADHD, it really is, functionality. It really is, how well am I getting on with my life? How easy am I finding my life around me? And in the end, that's what all health professionals are aiming for, to make somebody's life easier. And so recognizing, treating, providing support, providing a network, providing coaching, providing, that holistic approach and understanding to it really is a very pleasing thing to do. For the most part, there's always exceptions.
Thanks, Jonathan. Shruti? Just a comment on, do you find that if you're treating someone and maybe the parents don't realize they've got ADHD, but you can see it, how do you navigate that situation?
Well, like Jonathan, I would see families. I don't see couples, because sometimes there's a potential of a conflict of interest, but I would see mothers, daughters, grandparents. I'd even see three generations of the same family. Very often it's a young person who presents, and the 21-year-old, 22-year-old. And obviously with this generation, there's a lot more awareness, there's a lot more social media awareness. Kids are just a lot more aware of what is neurodiversity. And through the history, we talk about, the genetic link again. And they would usually pipe up saying, well, I think I got it from this parent, and I'm such and such. And I think I'm going to have a chat with my parent about I think they have ADHD. And very often it's sort of an interpersonal, familial sort of dynamic that happens, that the child maybe might speak to the parent then recognizes some of the difficulties that the child has. And I say child, I'm talking about 20s, 30s, early 30s, that kind of thing. What I also am quite big on, I'm quite big on involving the family when the patient comes to me and I say I have a 22-year-old. I very much, and say we have talked about the medication route. given the fact they are a major and they're still over 18 or of age, very often parents like to be involved, and often I have the young adults consent. So I try and involve families as much as possible, and also try and explain to families the difficulties that their child or their youngsters experiencing, because the evidence does show us that if the families, loved ones, and the support systems understand the difficulties that the patient goes through and understands the psychopathology, they're better able to support the patient, which actually helps long-term outcomes. So the evidence is very clear about that. So I try and involve families as much as possible, partners, again, with consent if it's appropriate, and we try and bring them in. Through the course of psychoeducation, and our sessions are psychoeducation sessions, a parent might say, well, actually, this sounds very much like me and resonates with me. Perhaps I might see you. And of course, I say, well, if that's if that's what you'd like to do, I'll be happy to see you. Because again, it's not just about the 3 cardinal symptoms. It's all about the subtle impact of symptomatology on the quality of life, interpersonal relationships, marital relationships, financial, business relationships, things like that, managing businesses, managing collegiate conflict, things like that. And if I can help a patient understand their condition, perhaps send the parent who might have their own business, or they might have a company that they work for and they have collegiate difficulties, then the parent for coaching as well, but give the parent the psychoeducation, and the parent understands qualitatively how much better their life has become by virtue, again, of the multidisciplinary input. That's then a win-win for the patient, both being the parent and the child. And so actually, it's quite seamless in my experience, because people see how much the quality of their child's life has improved. And the big one I see for the young adults is confidence. I see confidence go through the roof, the self-belief, I can do it. Everyone else is doing it. I know I can do it. I want to do it, but now I am doing it. And we see an exponential rise in confidence. And that, if anything, for a parent is the most heartening thing, seeing their child blossom. And they think, well, I can do that too. And then the parent comes. So it's actually quite a natural and smooth progression to treating the family unit. And again, a well family unit is a well parent, as a well patient.
Yeah, no, definitely. Do you also find that sometimes with an ADHD parent, there's a bit of resistance? Because some ADHD, there's this kind of, maybe they don't really want to see it, or they think that Absolutely. This is all a bit too much.
Our meeting last week was a lot about that, about parents perhaps who are having difficulty accepting neurodiversity, and that does happen. And again, it's not about faults. It's not about people not being amenable to understanding it. There are different emotions at play, and sometimes with parents it can be guilt, because they themselves are the parent and they didn't recognize the difficulties that their child was experiencing. And I explained to parents, a lot of these difficulties are within the child. They're thinking about the difficulties, that not necessarily difficulties that you can see. It's not like a broken leg, which is visible for all. The difficulties in ADHD are within the person, the intrapersonal difficulties. The person is, mulling over their difficulties within themselves. And again, particularly if it's a girl, it's very well masked. And I have to almost reassure parents that, we have to go through that whole, it's not about the guilt, it's not about the blame, it's not about you not picking this up earlier, not picking up your child's difficulties earlier. So there are a lot of emotions that a lot of parents, and stages of emotions that some parents can go through. There's guilt, there's anger, there's a sense of disbelief. Well, it's my child, I know my child best. Of course they do. And I would never, ever, dispute that with any parent, because every parent knows their child the best. But perhaps as a clinician, I can see something from the outside where I can clinically quantify difficulties that a parent perhaps attributes their child always having, and perhaps we look in ways at ameliorating these difficulties. Ultimately, I think most parents come around because when they see their child having a much better quality of life, their child achieving more, not just academically, not just professionally, but achieving more in what they want socially, in terms of achievements, of personal achievements, doing a project that they wanted to do, being able to, learn a new skill, ride a horse, whatever it is. It's incredibly gratifying for that parent, and understanding that this child has gone through that ADHD journey helps the parent actually understand this is not a bad thing. If this is empowering my child in some way, well, I'll go with it too.
Yeah. Yeah, I think the message there, you're saying it is a bit of a journey, that don't expect that parents
Not
may
all
not be on board straight
parents
away.
are as
Yeah.
amenable to the idea, because again, some parents go through different sort of stages of acceptance. And also don't forget, there's also the intergenerational and sociocultural divide. It's perhaps more prevalent and widely understood, say in our culture, for example, perhaps a different culture that where psychiatry perhaps isn't as widely discussed in such a sort of open environment. Something like ADHD is perhaps not as socially acceptable. And also, again, the generational issue as well, the intergenerational issue. That may also be difficult for some people to perhaps, it takes time for some people to work around.
Yeah, so it's a journey, which is similar to the coaching as well. It can take quite a bit of time for the ADHD themselves to accept the diagnosis. Jonathan, I'm sure you see that as well. There are some ADHDs themselves that really resist.
Yeah, I mean, what I often find is that, when you get back some of the questionnaires that family members fill out, there's an outlier. So you've got a patient scoring very highly. The history is very clear. You do your own assessment, it's very clear, and then you look at a parental question, a question that's been filled up by a parent, and they sort of score 0 on that. And you have to understand that attitudes towards mental health as a whole change by generation. It's not a sweeping statement. It doesn't mean everyone's like that, but certainly as a sort of general rule, the younger generations have more understanding, awareness, acceptance, normalization of mental health issues as a whole and neurodiversity. But again, your job is to listen to a person, understand how they conceptualize their difficulties, have that discussion. It's a difficult conversation in psychiatry where I think this is going on. A patient goes, no, I'm telling you this is going on. I find it more difficult when a patient tells me they've certainly got ADHD and I don't think they do. And that leads to a lot more frustration, I found, than when perhaps you spring on them that perhaps what they're suffering with it is related to ADHD. And they go, ADHD? Oh, wow, okay. It's very rare that somebody reacts badly to that, but being told they don't have ADHD and perhaps this is more anxiety and all the rest of it. Or, people find frustrating. I've had people demanding medications off me and I'm like, I'm not a shop. I still just, so I'm going to have to run. I've got to take my youngest trick or treating. I promised they'd be done by 6.
Yes.
I just have to say there was a comment again about costs and low cost options. I've just got no answers except what I said before regarding the get on the queue in the NHS, communicate directly with Psychiatry UK. And see what can be done. And it is a matter then of seeing if anyone will do a low cost assessment potentially. A lot of psychiatrists, myself included, do run a sliding scale, but you've got to ask for it. That's rarely advertised, but so there may be a possibility there. But the only other thing I can say is sort of, go onto the ADHD websites, help sites, and perhaps, join some of the forums. And there may be loopholes there that other patients, other people being diagnosed know about that perhaps we don't know about. And getting support that way could be really useful.
Thank you, John. Shruti, any last words?
I was just going to say, agree with everything Jonathan says. And I mean, there's some really good resources, free resources out there. The UCAN website, UK Adult ADHD Network, the Mind website as well. There's some really good links over there, really good psychoeducation links. There's a really good YouTube channel that I talk to people to use. It's a free YouTube channel. It's How to ADHD. And it's this lady, it's an American lady, talking about ADHD and the difficulties she encounters and things she does to manage the ADHD and explain it. So perhaps it's not the clinical diagnosis, but it's still helping people manage the behavioral difficulties and the difficulties that they may encounter on daily life. And again, this is not perhaps a clinical sort of a clinician's input, but it's a start somewhere whilst you're on the NHS waiting list or waiting list to be seen by anybody or somebody. I mean, the situation is difficult right now, and I empathize with that.
Well, thank you. Thanks, John and Shruti, for taking time out of your very, very busy schedules. John, I guess whoever needs to go trick-or-treating, go now. And we're going to take a break anyway, so we'll be back at 6:20. But thank you, Shruti. Thanks, John. And I'm sure we'll speak again soon.